Hi, and thanks for having me. Very interesting presentation that Sujit just gave us. And yet you can't help but wondering why some of that isn't happening already, right? I mean, there's so much technology out there and available, so many ways we can measure, and yet most of the history of technology and healthcare interaction is of technology bouncing off of healthcare and not really taking hold. And so what I'm going to talk to you, what I was asked to talk to you about today was, I am a person who tries to do big data and machine learning things, but I'm also a person who has tried and failed and then hopefully succeeded again at getting uptake of some of the things that we develop. And so I'm going to focus on what it takes to achieve uptake, primarily through the lens of my own failures. And those are numerous, so it could take a long time. A little bit, oh, down there, okay. I think about my research, so I'm a pulmonary critical care doc, but when I'm doing research, I think my patient is the healthcare system. And the main diagnoses are those on the slide there, but I'm going to focus on quality as variable. So Sujit was telling you about ways to make quality of care and outcomes of care better by personalizing them to the patient. And that is an extremely important need in the healthcare system, but there's a reason that it hasn't, that forces haven't coalesced, that sort of Sujit isn't being carried in on a throne to try and do more of what he's doing. And in fact, he's having to work to find partners. And it's probably not an accident, not a mere accident of history that Kaiser is one of his partners. Kaiser's in a very different payment context than the rest of healthcare. And so they might be interested in his work in ways that are different from how others in healthcare are. And what's going on here is that most of the problems of the current system are a reflection of how the system grew over time. So for decades, starting after World War II, payers were told that they were the agent of the employer or government, and their job was to make sure that doctors were happy, that doctors were able to give patients what they thought they needed. And because of the difficulties of measuring a lot of the things that we'll talk about, we have been talking about today and we'll continue to talk about, it was really hard for the payers to actually have enough information to know whether or not doctors were doing the right thing. And so the system evolved towards the doctor just tells the payer what they're doing and pays them for whatever the reported work was. Called fee for service, and it means the more work you do, the more you get paid. But it does not mean the better you do the work, the more you get paid. Whether the work was necessary, the more you get paid. It doesn't mean any of those things. And so it's a system built to generate units of service, but not any of the outcomes that matter to people who aren't getting paid in the system. And that's why the system has veered so far from where you would think it ought to be. Unfortunately, that hasn't gone away. So it means that if you come up with a great idea, it's not going to automatically get taken up into the system just because you had a good idea or you can see a way that it might possibly help patients. Payers at a national level have recently recognized that they want to change this. And you see written into both law and the regulations that are promulgated after law by the Department of Health and Human Services, some attempt to change the way, for instance, Medicare is paying for healthcare. This is a very sticky phenomenon, apparently, because it started in the Clinton administration, persisted through the second Bush administration, accelerated a little bit in the Obama administration, and it's recently been made clear by the Trump administration that they are going to continue to pursue changes in the way healthcare is paid for. So it will change, but you have to be really careful as you develop all of your wonderful technologies about how to make sure you're staying consistent with where the changes are going so that there can be any uptake of what it is that you want to do. In California, this actually started earlier than the federal trends, and I was involved in that earlier. And so the reason for me pointing out my failures is because I'm about as inside as you can get to the healthcare system. I got board certified in internal medicine first in 1994, board certified in pulmonary medicine and critical care medicine. I'm married to a nephrologist who's also double board certified. I work at the medical school, gets the most NIH dollars in the country. I have worked at the VA hospital, at our university hospital, at the county hospital. And when I got together and we started working on this, I brought together a group that we're going to talk about, the California Hospital Assessment and Reporting Task Force. And I said, well, I'm inside, but I know I'm not alone, and I shouldn't be alone, so I'm going to ask for guidance from people who represent really all the relevant stakeholders. So we convened the task force with support from the California Healthcare Foundation, and we brought in clinicians, so the doctors and nurses were there. We brought in hospitals themselves, we brought in insurers, we brought in consumers, we brought in employers and labor unions because they actually pay for the healthcare. And we said, what do you want to do? So we had all the people who had any interest in the healthcare system in the room, and we asked them what they wanted to do. And among the things they said they wanted to do was to save lives. And so in CHART, we started an ICU data collection system. It was not the kind of data collection system that you just heard about. This was before, at this point, 95% of hospitals have doctors writing notes with ballpoint pens. Really, it's only 2004, and that was the situation. So 14 years ago. So I thought at this time that I was really doing everything I could to make sure that this was not my idea, I was not the champion of it, and it was completely consistent with what people within the system wanted. When these stakeholders came together, consumers said, yes, this is what we want. Clinicians said, of course, this is what we want. We want to be able to save lives. Hospital leadership said the same thing, and insurers said, we want to see the system in California change from fee-for-service to paying for good outcomes, like better outcomes in the fewer deaths in the intensive care unit. And we did it. So although it was the old-fashioned way with human data collection, we were able to get data from every hospital with at least 200 beds in California, and most of the ones smaller than that. Essentially all the ICUs of any size in the state, and to develop highly accurate risk prediction models. The area under the curve there for predicting mortality is about what you saw in the literature. At the time, we streamlined the data collection system to make it as inexpensive as possible. We had lots of good training, and it worked. So when we started, this is observed to expected mortality, and above the line here is bad, and below the line is good. And what you can see is that this is about 100 hospitals. You'd expect, if it were random, you'd expect 2.5 hospitals to be above and 2.5 hospitals to be below, approximately. And instead, we have large groups above and below. So there was something to learn. There was non-random variation in this data, and there were lives to be saved. And we then went and saved lives. So when we started in 2007, the risk-adjusted mortality rate was 13.52% statewide, and within 3 years, it was down to 11.23%. To give you a sense of what this is and how you might think, why you might think that's impactful and that people might want to keep this system and the underlying technology in place, that given the size of California ICUs, that's the equivalent of preventing a September 11th about every 9 months. It was not purely from the measurement. So we set up the measurement system, but given the measurement system, in fact, it was not even primarily from the measurement. All the improvement came from people taking the measure. So now we're giving every hospital in California, here's how you're doing, here's who's doing well. They form quality improvement collaboratives. They work on really important stuff like treating infections better, making sure you're using sterile technique, all things that you need to do to have people have better outcomes in the intensive care unit. So, and I have this proof sitting in my hands in 2010. This is what's happening. So I, at least, standing there, thought that we were in a very good place for this to be a stable system that would persist for a long time. No reason for that line not to keep going down. Maybe it would asymptote out some because you can't save everybody and we're not going to live forever, but this should be great. Anybody know what happened in 2010 that might have changed the course of this line or changed the course of our apparent success? Anybody? Say what? Recession? No, the recession started, the recession came at the height of this, late 2007, 2008. No, the Affordable Care Act was passed, which should have been our friend, or so I thought. So remember I told you that the change away from fee-for-service accelerated with the arrival of the Obama administration. And really not with the arrival, but with the passage of the Affordable Care Act, which said we've got to switch away from the fee-for-service payment system as much as we can. But it also represented the entry of the federal government into deciding what to measure, deciding what was important. Up to that point, California had been the vanguard. We did a whole bunch of things, not just ICU. We reported things that might seem simple, like whether or not a mom learns how to breastfeed before she leaves, a new mom learns how to breastfeed before she leaves the hospital. But the Affordable Care Act came along, promising to the consumers and patient groups that supported it, there would be much more measurement of outcomes. What the hospitals heard was there will be much more measurement of, and it doesn't matter what, right? They perceived the Affordable Care Act as a giant unfunded mandate of data collection. And they had been living in this system where we had volunteered and they had a lot of voice in what got selected. They were getting a little skeptical overall about the whole thing because remember what I said in the beginning, the insurers said they were going to pay for things differently, and the insurers hadn't really paid much for things to be different. So now the hospitals are out here, and they said, we did all this work, we saved all these lives. Actually, we lose money on this, not so much because of the data collection, but because in the process of making ICU care better, we made ICU stays shorter. And you get paid a lot more for the patient to be in the ICU than for the patient to be on the ward. So we lowered their revenues, the insurers aren't paying more, and the federal government just announced what they see as a giant unfunded mandate. So I'm literally, in the space of about a week, I present this information and get told it's terrible. I show this slide and I'm told how terrible this is. And the beginning of the end happens when the hospitals start to announce they don't want to do this anymore because of the Affordable Care Act. I struggled, we tried, we lost. So how did I get so far out of whack? This is what you have to ask yourself all the time. Am I getting out of whack? Am I going to come up with something that's good and then get crushed anyway? And that's really easy for outsiders to do in healthcare. People don't understand often sort of where the healthcare train is going and how to hop on it and how to lay track that will help it go in the right way. Yeah, well, this is what happened. So I had that giant data collection system getting data on tens of thousands of patients from all around, a sample that Sujit would have loved, right? And suddenly we're irrelevant because they're more afraid of what's going to come out of Washington than what we can produce here in California. So this turned into a whole new task for me. I think it provides some hope for the future. The outcome of the task provides some hope for the future, so I don't want to just be a downer, but I want you to remember what happened to me and not let it happen with whatever you're trying to do. So I was told, as things fell apart, I kept saying, but the patients, the lives. And people said, well, yes, that's important. If you can find a way to do this at no data collection cost, then okay, Well, no data collection cost might sound like a really big task, but actually our data collection costs were pretty high because we were using humans to collect everything. So I then got on the train. This is how I end up at an XLDB conference, trying to figure out how to do this inexpensively, get to the same performance that we can get to inexpensively. And there's reason to believe it's possible. So big data offers a lot of opportunity. When we were using humans to collect data, we would say for any vital sign, go pick the worst value because it's too expensive to write them all down. Well, if you can get the computers to capture it all, you don't have to live within that constraint. So Glasgow Coma Scale is how close to a coma are you? 3 is you're in a coma, and 15 is you're normal. This is an example with 3 different patients. Is there a pointer? Okay, anyway, patient A starts up there at the top left, comes in normal, 15, and then goes down. That's bad. You might die. Good chance you'll die. Definitely bad. Whereas patient B starts at the bottom and goes up to normal by the end. An example of that might be someone who comes in with an overdose. They're in a coma, but if we get them out of it, then they're almost certain to live. And patient C comes in a coma and stays in a coma the whole time, stays 3 the whole time. That's terrible. If you got the human data collector writing down the one worst value, they're all the same. They're all a 3. But in fact, if you take into account all their observations of Glasgow Coma Score, you can parse those people apart pretty well. Does that make sense? So using data on, the scale of this is so tiny now, 35,000 patients. But compared to what we had already up and running, what we could get with human data collections, that's tiny. That's like a quarter's worth of data for what we had. But this is 2 institutions over 10 years that were able to give us their EHR data. We then did a bunch of really simple mathematical transformations, like we took all the observations of those variables, we just put in models with just the max and just the min, or the max and the min, or standard deviations and slopes. LBFS is linear best fit slope. And we were able to get to areas under the curve, that's this column here, you see down at the bottom of 0.896. So remember I said we were, with our human data collection, very expensive. We were at about 0.89 to begin with. So now with free data collection, or close to free, not entirely, but close to free data collection, and just using the vital signs, the stuff that's in the structured data, we were already to that same level. Well, myself and many others had spent years doing much more complicated stuff like that, saying if it's this diagnosis or if it's that, and we were essentially trying to create clusters based on diagnosis, and we had only gotten to the same area under the curve. So just using the structured data, but the bigness of it, we accomplished the same without all that intuition and feature engineering of, oh, well, this diagnosis should be treated this way and that diagnosis should be treated that way. The way to get to some of that while still doing free data collection is to do natural language processing of the text. So that was our next step. When we added in natural language processing of the text, we actually end up in a place here in blue where we're better than any ICU model ever created up to that point. And we're just taking data that's already created in the process of clinical flow and pulling it out of the EHR, which, once you set it up once, is not a very expensive operation. So we're struggling to get back to where we were before. So now we've taken our data collection costs and reduced them dramatically. We've actually improved the model. Now all we have to do is convince the clinicians that they want to have this big data machine learning thing, which they don't know much about, and then convince policymakers that they want to let that or choose those kinds of outcomes as a direction to move the incentives, to reward people for that kind of better outcome, better ICU outcomes. So the next step is to, so one of the things that CMS is Medicare is the big dog here. They get to decide for most people what the rules are going to be. And they said everything has to be drawn directly out of the EHR. So our hand data collection was killed the day that this rule came down. But we've lowered data collection costs. So the next thing we have to do is show the clinicians or get the clinicians to believe that this technical gobbledygook really means something. So now I'm showing you some of the words that have large weights, and a negative weight means you're more likely to survive. And MAE is the medical abbreviation for moves all extremities. If you're moving all extremities, you're not in a coma. Turns out that helps. If you're oriented, that helps. If you're agitated, believe it or not, that's actually a good thing. Anything that's intact, that's a word. Alerts, these words make sense. If you follow commands, weirdly, it's better to be agitated than to follow commands. I have 2 teenage children. That is for sure true. And then some things that predict mortality also make sense to clinicians. Like you might say pupil. Why is that a large value that means probability of death? Here, pupil doesn't mean student. It means your pupil here. And we check your pupillary defects by shining a light in it. If you're awake, we never do that. So we're only doing this if something is terribly wrong with you and we need to see if there's any brain activity. So we only write about the pupil if you're in a bad place. We only tap your cornea, like poke you in the eye basically, if you're in a terrible place to see if there's any response there. So, and if there's no response, you are unresponsive. So the output of the model makes sense to clinicians. For the sake of time, I'm going to skip through more of that, more showing that it makes sense to clinicians. Although people usually like this, so I'll just show you. You might not want to actually take all the words, because it turns out family relation words have a lot of weight. If your parent and your cousin come in, even after correcting for age, that's protective. On the other hand, if your daughter comes in, that's bad news. And it turned out that the single most protective family or relational word was girlfriend, and the worst relational word was daughter. But you don't want to necessarily include those words in a risk adjustment model where people are going to get paid based on it, because next thing you know, everybody's going to have a daughter somehow. They might have a strep infection, the daughter of Pseudomonas, or something like that. You have to constantly we have to be thinking through how this model is working and how it's going to play out under incentive systems to be able to explain to policymakers how to use it. Okay, so the implications for you. Okay, so now we've done that. We have to publish that and get the clinicians entirely behind us. And then we've kind of been waiting about trying to push this to the policymakers, because we weren't sure exactly what the new administration was going to decide was important. As you, I'm sure, have seen, there were a lot of changes in policy direction, not just in healthcare, but I'm talking about in everything. There were, a lot of things are different under the new administration. So we've been trying to figure out what is the right way to approach them. But recently they announced that they do want to continue the programs under the Affordable Care Act, where they change the basis of payment, and they want to reward more on the basis of outcomes. So I think there's a window there, once we have this published and we can point to it, there's a window there for us to go back to them and say, well, people used to do this a lot, and they used to work hard using models like this, only ones that aren't as good, to try and improve patient outcomes. Following the letter of the Affordable Care Act and your recent announcement saying you want to reward based more on outcomes, here's a great opportunity for you to reward more based on outcomes. Time will tell whether or not we've gotten ourselves back in alignment with the incentives of the system. But the key thing I hope you take away from here is it's not enough to have a good idea. It's not enough to have an idea where you could imagine it could help somebody. It's not enough to have an idea where you can prove that it would help somebody. If you are out of alignment with the incentives in the system, the incentives to the providers in the system, you're not going to get uptake, and you might even lose what uptake you've had. Thanks. And all of those methods on Sujit's slide about random forests and SVMs, et cetera, they're open to play in here. A lot of opportunity for people who are interested in, not just in ICU, but in everything else.
Thank you. Questions? Uh-oh. I think we have the post-lunch lull.
So science doesn't have to be complex. What you have done, the chart method, is a very simple, just gather this information. It's instructions to the clinicians to gather the information. Fast forward to today, everything we look at, gadget this on his head, on his toe, on his ankle, everywhere we can. It's IOMT, is it what Sujit called?
Yes.
Yeah. So is there a need of this proliferation of devices? And would that skew your result? Or would you just do the same test today? Would you get the 2.5% decrease in mortality rate you have seen or more?
Well, I think the big issue is that it wouldn't matter if you could put more sensors on if no one's willing to use the data to change things. And you have to have a policy context in which people say, what I'm reaching for is not more recordable, billable days of ICU stay. Rather, it is ICU patients live. They leave here alive. And then you have much more of a pull. So I mentioned it's not an accident that Sujit works with Kaiser. If you think about that, Kaiser gets paid a pot of money each year to take care of people. They actually have the incentive and Kaiser patients tend to stay Kaiser patients for a very long time. They actually have the incentive, and they also are, it's in their insurance company and the hospitals and the doctors all rolled into one. So they have the incentive to take that population focus and say, Sujit, go to town. Show us every possible way to make better outcomes because we're going to get the long-term payoff of those. But the rest of the system doesn't. Well, the VA does. There are a few places like that do. But the vast majority of the system doesn't. And the more information you throw at them, the more stressful they find it. They're like, wait, we can't even deal with that information. We don't know what to do with it. So if you want to have your ideas brought in and held close by the people who actually run and control the system, you have to first ask what actually runs and controls them.
If I may just add one thing. I'm not going to name the hospital system or healthcare provider, but one such provider that we were starting to work closely with, essentially that relationship is a little sideways, essentially because of this system that the director of this particular institute wants to do the work, but there's no incentive to reduce cost and to do the things that...
Yeah, to be clear, the critical care clinicians, the doctors and nurses in ICUs around California loved this system and did not want it to go away. And they worked super hard with the data and they made a huge difference. It was the hospital CEOs that said, I don't want to pay for a data collection system that will lower my revenues and not get rewarded. And while that sounds cold, you actually can see, if you extrapolate that and they keep paying for things that they don't get paid for, they can't have a hospital, they can't provide the services that they've got. So you have to figure out your way that you are in sync with what they're trying to do. And the truth is most of what comes out of the tech world isn't. There's nothing in a Fitbit that has in any way addresses the incentives for providers.
Well, thank you very much for
Thanks for
very
having me.
interesting and motivating talk.